Good afternoon and welcome to today's OR Today webinar, Improving Patient Safety with Safe Surgery Checklists. Today we are joined by Jeff Robbins, founder and CEO of LiveData, and Aileen Killen, LiveData's Director of Perioperative Operational Excellence. OR Today's webinars would like to thank today's sponsor, LiveData. LiveData is the leading provider of data-driven surgical care that empowers and assists perioperative teams to optimize operating room performance, increase staff satisfaction, improve communications throughout a patient's surgical journey, and enhance patient safety. For more information, please visit livedata.com. I would like just to mention that OR Today is pleased to support two events this September. Periop Connect will take place September the 8th to the 9th at the Omni New Haven Hotel at Yale, New Haven, Connecticut. So for more details about that, please visit periopconnect.com. The second event is the Georgia Council of Perioperative Registered Nurses Annual Conference, which will take place September the 29th and 30th at the Atlanta Evergreen Lakeside Resort in Stone Mountain here in Georgia. For more details for that, please visit gacouncilnurse.org. Details of the shows and much more can be found in the handout section of your webinar dashboard. Today's webinar is eligible for one education hour. You can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1CE certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Let's kick off today's webinar by giving away one of our OR Today live lunch bags to the attendee that can tell me the answer to the following trivia question. March is National Red Cross Month. What is the name of the nurse who founded the American Red Cross? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, our presenters today are Jeff Robbins and Aileen Killen. Jeff, you may begin whenever you're ready.
Linda, thanks very much. I'll be very brief. You know, in the hierarchy of the why, the what, the how, as a techie, I'm really more about the how. You're here to hear some interesting information from Aileen Killen, who can explain the why and what in great depth from her wealth of experience. So anyways, I'm pleased to be here and very pleased to pass the baton to Aileen.
Good morning, good afternoon, wherever you are in this country. And thanks for joining us today. Just one brief, my bio's on the screen, but I just need to point out that after decades of being both a perioperative nurse and a patient safety officer, surgical safety and especially surgical safety checklists are a passion of mine. So I apologize ahead of time if I get really passionate about a couple of topics we're going to talk about today. And if I say the same thing more than one time, it's because it's a point that I think is really important over the years that I've learned from being in those two roles. Next slide, Jeff. Dave, sorry. First slide. Thanks. So I just want to briefly tell you what we're going to talk about for the next 30 or 40 minutes, and then we'll open it up for questions at the end. But first, I want to start with a little bit about why we need checklists, what makes a good checklist, do they work, some best practices, including implementation challenges and strategies, and how technology can help us. You might think, why are we talking about this? We've been doing it for 20 years, but the number of people who have signed up for this webinar convinces me that people are still having challenges in your operating rooms on how to implement safe surgery checklists to do it well and to make a difference for our patient. I know when I was in clinical roles, we had challenges every day with checklist compliance. So that's why we're here today. Next slide, Jeff. I keep thinking Jeff's moving the slides. I'm sorry, Dave. So just a little history lesson on how we got to where we are today in 2023. Those of you who have been around for a while will remember that in the mid-1990s, there was several high-profile wrong side surgery cases amputation of a wrong leg, surgery on the wrong side of the brain. And the perioperative world started to think about what we could do differently to make that not happen. And every organization started their own practice on how they were going to mark surgical sites. Some of us marked yes on the correct knee, some of us marked no on the incorrect knee, some of us did all kinds of crazy things to try and identify. Some of the patients marked their own knee, and then when they got to the hospital, the incorrect thing was marked. So the American Academy of Orthopedic Surgeons, who have a high risk for wrong side, obviously, because most of what they do has laterality, started a program in about 1998 that was called Sign Your Site. And that's when we started to see the initials of the operating surgeon on the site. About 2001, an anesthesiologist called Peter Pronovost at Johns Hopkins really started to think about this, how a checklist could help us. And he started to do some work on checklists both in and outside the OR. In 2004, Joint Commission took those two initiatives and combined them into what we've known now as the Universal Protocol, which consisted of the timeout mostly, and it became part of the National Patient Safety Goals. However, as you can see back to the very first bullet point, we were very late to the game, and airline pilots, especially the fighter pilots of the Chuck Yeager era, had been using checklists since the 1930s. We hear a lot of comparisons to checklists, and some people say that it's not a good comparison, that patients in operating rooms are very different than airplanes, but there's a lot of lessons to be learned, and we shouldn't throw them away. In 2006, Peter Pronovost built on his work and did a project with all the hospitals in the state of Michigan, if any of you are on this call from Michigan, where they were looking at central bloodstream infections and central line placement. And because of the work of all of those hospitals with Peter, they got their central line infections down to as near zero as you can statistically get. We'll talk about what's happened since then, but that was a big push again in the world of checklists. In 2008, the World Health Organization got together a group of people from all over the world and launched the Safe Surgery Program. And out of that program came two seminal pieces of work in 2009. One is the Checklist Manifesto that was written by Atul Gawande, and the second was an article that was published in the New England Journal of Medicine based on that Safe Surgery Program from 10 countries around the world. And they reported on a decreased morbidity and mortality in all of the countries based on the use of the checklist. So that's when we really all started to embrace this idea of checklist. But here we are almost 15 years later, and we're still struggling with it. So just going to give us some information of what we learned since 2009 for what works and what doesn't work, and see maybe we can help ourselves do better on this checklist phenomenon. Next slide, Dave. So why do we need a checklist? We need a checklist because we're human beings, and human beings have worse memories than we think we have. We're all fallible, and we're more fallible when it comes to routine tasks that we do over and over and over again, until those tasks become overshadowed by something more pressing, which happens to us all the time in the perioperative arena. You're doing something, you've got this checklist in your head of, I check the bovie, I check the suction, I do this, I do that. And then all of a sudden the patient comes in the room and they're very anxious. And so you stop paying attention to your routine and you take care of something more pressing. And when you go back to your routine, you may forget a step. So the point of checklists is they're all or none. If you use a checklist and you only refer to it once in a while and say, oh, I know the first 5 steps, I'll only look at it later, don't even bother. You skip one point on a checklist, you might as well have not done it at all. The other thing we tend to do in healthcare is if people aren't performing a task successfully, we say they need more training, they need more education, let's do an in-service. What the early fighter pilots taught us, that more training doesn't help in a complicated situation. When they got a new plane, they didn't train on it. They made a new checklist that was simple, brief, and to the point about the things they had to do in this new complicated plane. And we should take examples from them. Next slide, please. So earlier I mentioned Atul Gawande and the Checklist Manifesto. It's now 15 years old. I would still recommend, if people want an easy read about a lot of nuances of what to do and how to do a good checklist, it's a really quick, easy read. And the man is a phenomenal writer. He writes really, really well. The takeaways for me from his book are twofold. One is that there are two components to a checklist. There are physical tasks to discuss, but more importantly, there are communication tasks. We're going to talk about that a lot in the next little bit here. And also that the checklist was designed to be a balance between clinical freedom and the freedom of clinicians to care for their patients in the way that they think is best, but also putting some discipline around it so that we don't miss critical events. Their word, not mine, but things that you think might be stupid to put on a checklist might be really critical if you skip it. And so it should be on your checklist. And it also was designed to ensure that people talk to each other, they coordinated with each other, and they accepted responsibilities for their own role in the perioperative process. Next slide. This is what the original safety checklist looked like from the WHO. And I just want to point out a few things, and then we'll talk about how you can adapt this to your own use if you're not using it now. So one key component is that the surgical checklist from the WHO has three components. It's not just a timeout. It's got a sign-in or briefing component and a debriefing component. And together they comprise the surgical safety checklist. It's not just a timeout. The key points about this checklist when it was designed in the early 2000s was it shouldn't be comprehensive. It's not everything you need to do to get a case off the ground, but it's also not a to-do list. So it shouldn't just be a list of tasks. It's items that are high risk if they're omitted or overlooked. They might be different in your situation. So they encourage people in their implementation guide to modify it, to add things for local use. For them, local use might have been a different country. For us, local use might be the difference between your main OR and an ambulatory surgery unit that does different kinds of cases, or two different facilities in a large system. But modifications are crucial to the success of a surgical safety checklist. And they also suggested that if you do some really specific procedures with high complexity, that you either have an additional checklist or you add some items to your checklist, like, do we know how to disengage the robot when we're getting ready to do a robotic case? We see a lot of our clients have a specific question in their timeout for cataract cases because the Joint Commission's reported for years that one of the most common wrong something surgery is a wrong intraocular lens implant because there's so many choices. So a lot of people have a question to check the implant at the timeout. Next. So what makes a good checklist? As I said, there are some actual checklists about checklists in that book from Gawande, but I want to point out just a few things that I think are really important to think about if you're trying to modify your own checklist or to improve on your process of timeouts. So the first one is behaviors, because we talked about that's an important part of it. And the first thing that you need to think about is deciding who's going to activate the timeout and what the pause points are. So if you go back to that WHO checklist, in each one of the categories, they make a suggestion about what time in the perioperative process this checklist should take place, and at minimum, which providers should be at that briefing or debriefing. The best example I ever heard about this was an article in the AORN Journal a few years ago where a facility that, it was actually in a cardiac cath lab, but after it worked, they did it to the operating room. They couldn't get people to stop what they were doing to pay attention, and they actually had a Tibetan gong in the room, and they would strike the gong when it was time for everybody to be quiet. I'm like, I want to bring that into my operating room. I want a gong. The other behavior that I think is one of the most important, if not the most important behavior in a timeout, is everybody should have a speaking part. The checklist was not designed to be read by one person with everybody else either nodding or not paying attention. We'll talk more about how you can make that happen, but both patient safety experts, people who study language, people who study how people react, will tell you that if you hear your own voice during the timeout at the beginning of the case, you're more likely to speak up during the case if you see something that's not in line with what you expected to do. The other thing about these checklists, it's called a do confirm checklist. So when you're doing these checklists, most of these activities should have been done already, and you're confirming that they're done. It's not something you're reading out and then people stop and do that activity. In terms of formatting your checklist, whether it's on paper, in your electronic health record, on a whiteboard, or as you'll see with a technological solution, there's a couple of things to think about and just how the checklist looks. The first is it should be between 5 and 9 items, according to Gawande, and a good timeout should take you 60 to 90 seconds to do. So people who tell you that they don't have time to do a timeout, I would say you don't have time not to do a timeout. Also, they shouldn't be wordy. They shouldn't be somebody's Ph.D. dissertation. They should be using simple words that the people who are actually using the checklist are familiar with. They should be words that the profession uses. In terms of physically the type you use, they should be both upper and lower case. So people who study checklists, Boeing is the best example. They studied this for years with pilots. It's actually easier to read sentence case than to read all caps, even though we think we should put things in all caps to make it stand out. That's not actually the case. And there's a specific type that you should use even when you're doing, Word documents or whatever, and it's called sans serif. What that really means is each one of the letters is distinct. It has boundaries. The one we typically use in the US is called Arial. The checklists use something called Helvetica. I can't tell the difference between the two, but it really makes the letters separated so that if you're putting a word that has a C and an L next to it, the L doesn't move over into the C space because it's a thin letter and it looks like a D. So these are just some examples of things you need to think about, and there's lots of resources available to you if you're trying to make a good checklist. Next. The other person I just want to talk about for a minute is somebody else that we can learn lots of lessons from, and that's somebody that we've all learned to call Sully, but Captain Sullenberger, who landed Flight 1549 in the Hudson River in New York. These lessons to learn came from an article that was published in a journal called Chest in about 2009, right after the event. And it was written by a thoracic surgeon who wanted to share with his colleagues things that we should be learning from the aviation industry and from this example. So the part that was most interesting to me, and that I didn't know until I started to read about this event, was the plane's taking off, and as it's taking off, the first officer was actually flying the plane. Sully wasn't flying the plane. He was doing whatever the other person does when somebody else is flying the plane. So think of that as what happens in the operating room. Similarly, a resident might be opening and the surgeon's observing him. But as soon as they knew there was a problem, Sully took over. And he announced he was taking over, controls are mine, get the checklist out for stalled engines. And so then the first officer became in charge of the checklist. And nobody ever knows what that guy's name was. And just for the record, it's Jeff Skiles. But he is the one that was responsible for making sure that they did every step they needed to do, both in trying to start the engines, deciding they couldn't, and then what was next. So it really demonstrated the communication between the two of them, and then to the flight attendants in the back, how important these non-technical skills are. I think the most important phrase in this article is that he said that although only one person can be in charge, others can demonstrate leadership. And I think that's a role that we need to embrace in the operating room when we're doing this kind of work. And then the other thing that they realized was now they were going to have to evacuate the plane. Now they're in the water. Well, nobody's ever evacuated a plane in their career. They might do it in a simulator, but they had special checklists that were just for those rare occurrences. And that's something I think that could be a whole nother webinar about critical checklists and things that we should have checklists for that we don't do often to make sure we're doing it. But if your checklist is in a book and you don't get it out, it's not very useful. Next slide. So does this actually work? So most of us who learn QA learn that there's 3 things that you can look at: structure, process, and outcomes. This work is no different. So what the framework should be is you putting a structure in place, the checklist. to improve your care processes, whether that be the antibiotics, hypothermia, whatever it might be, and that you expect your outcomes to be improved. And as I've said before, and I'm going to say again, the checklist needs to be used correctly in order to get the process and outcome steps right. However, looking at the literature over the last 10 or 12 years, the reports in the literature about do checklists work have been very equivocal. And we'll talk about some of the people who say yes and some of the people who say no on the next slide. Interestingly, when I was doing research to update some of the research studies for this talk, most of the studies that have been done in the last 10 years that have been published have been done in Europe. We've studied this very little in the United States. So some of this has been done in academic medical centers in countries in Europe, across different hospitals in different countries, but I think it's all relevant to us. And I just think it's interesting that there weren't very many published US articles about the work of the checklist. So the yes column here is from a study that was done in Norway in 2015. And they had the luxury of having two different hospitals where they could randomize checklists in one and no checklists in the other. And after they controlled for everything else that was different about these two hospitals, they found that in the hospital that used the safe surgery checklist, they had a decrease in surgical complications from 19.9 to 12.4, which was statistically significant. And they decreased their length of stay by almost a full day. Other studies that have been done in pediatric populations in emergency surgeries, both in the developed and developing countries, have proved that checklists work to decrease both morbidity and mortality. And almost every study has concluded that it's improved information transfer and communication. The people who question whether checklists work are on some of the other side of this column. So the study that Pronovost did in Michigan, lots of people tried to replicate. It was done in the UK, a large study, and they were not able to replicate his success in decreasing central line infections, whether that was because they focused on the tasks, not the communication. You know, more work needs to be done there. But there was also some studies in Canada after the article was published in the New England Journal, and in the province of Ontario, they couldn't replicate the results of that WHO study of decreased morbidity and mortality. Some studies say there was no reduction, but there was no increase. And the other thing to think about this is your culture of safety in your organization. So most of us, I think, do a culture of safety survey. Joint Commission was mandating that it be done every couple of years. If you can't get the data for your specific unit or your operating room, I would suggest trying to do a culture of safety survey before and after you do a big implementation project like this, because what some of the studies have found that if you don't have a good implementation process and people are at odds about what the goal of the project or the checklist is, that teamwork actually was negatively impacted. Dave, next slide, please. One more way to look at do checklist work is on measuring some specific items that we hope will improve based on those checklists. So the checklist was not designed to improve efficiency or to improve workflows, decrease workload in the operating room. That was not the design. It was designed for safety and communication. So on the things that it was designed to do, studies will show you that yes, the checklist works on sharing critical information, on better decision making, on openness about knowledge gaps, on improved team cohesion. Although it wasn't designed to do it, many studies also look at the efficiency in the operating room when checklists are used, and they did not increase the operating time. In fact, there are studies that show that if you take these 2 minutes at the beginning, you might save upwards of 20 or 30 minutes during a case when you're not saying, oh, by the way, I need this, and then you're waiting for it to come from central processing or wherever. Checklists, briefings, huddles did not negatively impact first case on-time starts. They did not increase same-day cancellations. And they actually helped with reduction of costs of disposable items in the operating room, because if you're doing a good briefing, you can say, this case might be a little different. Don't open that expensive supply until we get in and see if we need it. And that has helped both to disposable costs, and all of those other things. So next, I just want to talk about one last study, and this is what's called a meta-analysis. So these researchers were looking at the WHO Safe Surgery Checklist. They looked at 20 studies that were done by different people in different countries with different metrics. And when you do a meta-analysis, they use sophisticated techniques to analyze all the data together. And it gives you a much better picture of what's going on because you have bigger numbers of cases. So what they found is what we would hope they would find, and that things that were explicitly designed on the Safe Surgery Checklist were positively impacted. So for example, if you have a question about was the antibiotic given 60 minutes before incision, in those cases there was less surgical site infections and less sepsis. If you have a question about what's your anticipated blood loss, there was less use of blood transfusions. So the studies indicated that what I was trying to measure, if I had a question about it on the Safe Surgical Checklist, it was positively impacted. The interesting finding for me is it didn't affect things that it wasn't designed for initially. And most of the early checklists did not have questions about VTE prophylaxis. And that was the one clinical outcome across all of these 20 studies that wasn't positively impacted by the checklist because it wasn't specifically asked about on the checklist. And I think now most people have added VTE to their checklists. So next slide. So just as a reminder, when you're designing your checklist or you're looking at studies and you're trying to find some support for an argument you're making about why you should do this, efficiency and workload were not part of the original design, but you will find some studies where people looked at that in addition. And the whole point of the checklist is to be slower in the process initially so that you can speed up later. So we call it go slow to go fast. The point is not to do a quick checklist. If you're doing your timeout in 30 seconds, you're probably not having a good conversation. And many people say, well, I'm only doing a 15-minute case. I'm doing an endoscopy. Just because you have a short case doesn't mean you should have a short timeout. And there might be many things to discuss about a patient who's not having general anesthesia. So just be wary about cutting corners and cutting the wrong corners. Okay, on the next slide, we're going to switch for a minute to talk about best practices. So the best practice of the WHO checklist is that it has 3 components. These are slides from the LiveData solution, which we're going to talk about at the end, but just so you can see how we divide this up. So there's the briefing checklist that is done by anesthesia before they turn the patient over to the surgical team. There's the timeout, next, Dave, which is the traditional timeout from Joint Commission with some of those extended introductions, etc. And then the third one next is the debriefing. So when I talk about a safe surgery checklist, I'm talking about all 3 components of this always, not just the timeout. Next slide. So with our clients who have embraced the use of the safe surgery checklist, and in the research, we see that the briefing is done actually quite often, much more so than the debriefing, which we'll talk about in a minute. There's a study published in 2012 by a group of Dutch anesthesiologists, and they were looking to see if the briefing impacted their care, and also they were including the patient in the briefing, and they looked at, did that make the patient more anxious if they were hearing this conversation going on in the operating room, because that's been a debate for a long time. So they thought of it as a team meeting. The team's having a meeting before we start this case. And they talked about things that they needed to do together for this case to get off on time and safely. They found that it improved team cooperation, it improved motivation, it improved discipline, and it improved some of their anesthesia outcomes. They measured the safety culture using something called the Safety Attitudes Questionnaire, and it improved the safety culture in their operating room. And the efficacy of the entire checklist was correlated with the performance of the briefing. So if people did a briefing, the timeout was better, the debriefing was better, and everything was better. Then they asked the patients after the fact, what did they think about this activity that was happening with them, maybe awake, maybe a little under conscious sedation, maybe just with some pre-op meds on board. And surprisingly, most of the patients said either they didn't remember it happening, it didn't upset them. Some said it was comforting to know this conversation was happening, and some just didn't remember at all that it had happened. I think a lot of people have this debate about should the patient be there, should they not be there. To me, the briefing is more of a team activity outside of the patient identification process. Obviously, the patient identification process has to take place with the patient awake and alert if they can be, or with the family if they can't be. But after that, the rest of this discussion is really for the team. And there are some questions on the safe surgery checklist, what's the anticipated blood loss? I'm not sure if I was the patient, I would want you to be talking about that while I was still awake. So I think you need to decide in your organization when's the best time to do this, who are the best people to be involved, and should the patient be involved or not. Next slide. So many of us think that the timeout checklist is the safe surgery checklist, and it is one component. And I'm just going to talk about this a little more because I think it is the crux of what we talk about in the operating room. So this is a study that was published in the International Journal of Surgery out of Germany in 2019. And they looked at their timeout as having a couple of different layers. And I think this is an interesting way to look at it and a way for us to decide what we should add and not add to our traditional timeout requirements that the Joint Commission requires, which are only at this point, I think 5 or 6 different items. So they talk about, of course, the core components have to be there: patient identification, verification of site, allergies, laterality. Then they talk about the customized section of a timeout. And those are the things that we've added based on either our surgical outcomes databases or things that our quality department is tracking or things that we report to the American Academy of Surgery or whatever. And those are things like antibiotics, normothermia, blood glucose levels, beta blockers, VTE. So think of those things as an expanded part of the timeout. I also have found in many places when I go there and I see the timeout added questions, you can tell what kind of never event or near miss a site has had, because in many root cause analyses in my career, the solution to the problem was, we'll add this to the timeout. And so you can see things that people have had issues with added to the timeout. I was working with one site, and in the timeout was a question of, is the surgical safety strap on? And I said to myself, but not to them, oh, somebody must have fallen off the table. So be careful of that. If you're going to do those kinds of things, you should probably add it for a while, monitor it, and then when the process improves, think about taking it off again, because many people won't remember why that was there after a couple of years. The next part is what you're going to hear from me over and over and over again, is my favorite part of a good timeout part of the safe surgery checklist. And that's twofold. One is expanding it to include team member introductions. And 2 is that each person has a speaking part. You've heard those before. A lot of people say it's really awkward to do team introductions. We work together every day. We know who everybody is. It really doesn't feel natural to introduce ourselves to each other all the time. And I would argue that there's a way to get around that, and that is when everybody has a speaking part, whoever's activating the timeout, and hopefully that's your senior surgeon or anesthesia, calls people by name. It proves you know who's in the room, and it gives that personal aspect of a team of who's on my team today. And the most important thing a surgeon can do as the last comment of a timeout is introduce a safety statement, and we'll show that to you in a little bit. This group of surgeons in Germany also suggested that you should be careful about which items that you want to customize and which part of the safe surgery checklist that belongs in. So for example, we were working with one client who had a question in their timeout about the patient's pregnancy status. Well, I would contend after they're asleep, prepped, and draped, that's a little late to ask that question. So either you should be asking it in the briefing or in the pre-op holding area or someplace else. So just don't think automatically that the timeout is the place to put things. Another study by a group of orthopedic surgeons, after they initiated some better timeout procedures, said that they concluded that 15% of wrong site errors that were near misses and didn't cause wrong site surgery would have been picked up by a better timeout. And this to me is shocking, but 85% of wrong site errors that actually resulted in wrong site surgery, they felt could have been prevented by a better timeout process. Next slide. And finally, we come to the debriefing. We find almost everywhere we go that this is the least compliant part of the safe surgery checklist. If you're a quality improvement person or a process improvement person, it's probably the most important part. But a lot of times the surgeon leaves, nobody wants to do the debriefing, we don't know what to say, we're trying to close, we're trying to count, we've got lots of other things going on. And once again, this is just another time that you have to have a pause point and somebody has to activate it and say, you know, Dr. Jones, before you leave, can we talk about this case? What questions you put on the debriefing will oftentimes be decided by your quality and safety department. We tried to put these on our debriefing in an organization. The last place I was the OR director, about what went well, what didn't go well, and what could we do better. And the quality and risk management people literally freaked out. They said, you can't ask those questions because people then will go looking for an answer. And if there's been an event, it's discoverable. So what we had to do was, these were part of our discussion, but we had a process outside of the EHR, outside of our debriefing checklist, where we would record those answers and escalate them up to somebody to help us fix. And the important part of a debriefing is, if you didn't have a good briefing, there's no point in debriefing, because if you don't know what the plan was, you didn't know what went well or what didn't go well. So it really is, again, just re-emphasis on the fact that this is a three-point process. All right, next slide. I'm going to switch real quickly in some of the challenges we know that happen when people try to implement the safe surgery checklist. Next slide. So initially, a lot of people said, oh, this is simple. It's a checklist. We're going to do a timeout. They made a list. They put a piece of paper together. They put the questions in the EHR, and they said, go do it. Well, that's a very naive approach, and we know that's not how things become sticky. It needs to be an implementation plan that's decided both at the top levels of the organization and also with the people who are actually going to be doing it. Everybody that I talk to in the patient safety world, whether they be physicians or not, say that the ability to have a good implementation depends on physicians' ability to be able to explain it, to demonstrate the checklist, and to not take it lightly. I also hear, I don't have time for every nurse to have an hour of in-service on this. We can't pull these people out. The surgeons won't do it at their meetings, whatever. The ROI on this is, from the literature, that if you prevent 5 serious complications a year, which every study will tell you you can do, it neutralizes the cost of implementation. So if you need an argument to do it, that's it. Next slide, please. These are probably no-brainers, but just so that they're all in one place, the best implementation strategies start with analyzing your barriers and your facilitators, both people and processes, analyzing your safety culture, adapting the checklist. Notice it doesn't say adopt. There was nowhere in the implementation guide to WHO that says everybody should just adopt this as is. You really need coordinators or champions in each of the disciplines. You can make a nice video of a perfect timeout, and it doesn't take much. You can now do it on your phone. There's lots of them on the internet, but what we found was that if it wasn't the people that we were working with, the surgeons didn't want to pay attention to it. Everybody poo-pooed it. Oh, this looks like it's fake, whatever. You need to do a video of your people doing a perfect timeout and then show it to everybody. When I was doing this at first with LiveData, as I was one of their clients many years ago, we asked all of the nurses who we should videotape. We had about 100 surgeons, and we said we need a senior surgeon who the other surgeons respect and who does a good timeout. And unfortunately, we came up with one name out of all of those surgeons, but he agreed to do the video for us, and then everyone had to watch it. They went to every surgical meeting, and people had to watch how a good timeout could only take 1 minute. You need to provide feedback and ongoing monitoring of how you're doing, and we'll talk about that in a little bit. And then the next slide talks about some guidance on adapting your checklist. And the World Health Organization encourages customization, but they are very clear about don't add too many items, don't take away too many items, and don't add items that are just process checks. You really need that balance between communication and process checks. Next slide. This was a study that was done and published in the Journal of Surgical Research a couple of years ago, and they asked people to send them checklists. They got 155 with all three components, and 100% of them had been modified. The modifications were not in line with the guidance for implementation. There was more text and more items than on the original checklist. A median of 13 new items were added to the checklist. So in addition to the 5 to 9 that you're supposed to have, they had 13 more. And a median of 5 items were removed. And what's interesting on most of them, the items that were removed, one of the most common ones was in the briefing. People took out the question about pulse oximetry. That's been a standard in this country for years, but in the original work across 10 different countries in the world, it wasn't the case. And that was a really critical step for pulse oximetry. So it makes sense to take it out here if every patient, every case, every time has it. But the next most removed items were the questions about anticipated critical events, anticipated blood loss, and case duration. So you really need to be wary of removing items that are your bias. Next, I'm going to skip over this next slide for a minute because this just talks about what we know. Most of the time, the burden of initiating these times out falls to nurses, and we need to figure out a way for that not to happen. And also when you're implementing, communicate the why and not just the how. Next slide. So now I'm going to turn it over to Jeff, who can spend a few minutes telling us how technology can help us do all of these things that we've been talking about.
Thanks, Aileen. I'll be brief. Even though I'm a lifelong techie, I'm definitely skeptical when it comes to the intricate kinds of work and caregiving that's done in surgery. It's a daunting challenge actually to figure out ways of having technology that's only additive and doesn't get in your way. And so in developing our line of products, we've been really focused on layering screens on top of existing EHR practices and bidirectionally integrating them. So we never make you type something in you've already typed in, no double documentation, and try to automate the process of capturing that data from wherever it's coming from and get it up on screens when it matters, just the subset of the data that matters. That's our goal. You know, we're not perfect. Obviously, we don't always achieve that. And so, you know, in this talk, I mean, we've been focused on the timeout, and one of our products, LiveData or dashboard, has a patented electronic checklist system we call active timeout. And part of what makes it active is rather than printing up a prefab copy of all your checklist questions, we're actually populating the answers with what's been documented thus far in the EHR. So when you get to a laterality question, for example, if someone's made a mistake in the documentation, you actually can fix it concurrent with the case, and our system will automatically refresh the display and you'll see the correction. So it's a great way to align the documentation with what's really happening. And that kind of technology, I think, does help make the tech more useful in spending that minute or two with your attention really focused on questions and their answers. And we don't have time to go into it, but in that monitoring process, when you have a change you're making and you're trying to monitor compliance and acceptance, et cetera, automatic analytics that keep tabs on each and every case, questions being answered, the amount of time spent, so you can get a flavor of, you know, what kinds of cases might be emergent and not have time for these questions. The so-called easy or simple cases where people skip questions, that kind of thing. That helps you get a flavor for how the teams are actually approaching the checklist. Next slide. And so the goal of the product was to make something that would engage the whole team in the OR. Ideally by having a screen on the wall so everyone knows when the timeout's really happening. Make sure the timeout isn't sort of an after the fact, oh, we document that we did a timeout, I'm pretty sure we did one, to no, we really stopped and did one. And I don't think I need to belabor how it works. I think Aileen's covered it pretty well. So why don't we get to the next slide?
The one point that I do want to make before we leave this is you saw a little clicker in the corner. And that clicker is something that the nurse can wear on a lanyard around his or her neck. And what it means is I can document my timing events and my timeout from anywhere in the room. I'm not tethered to the desk. I'm not writing it on my scrub suit. I'm not writing it on a piece of paper and then documenting it later. I'm documenting in real time while I'm standing next to the patient, while I'm standing next to the surgical team, and all of the documentation changes in real time. And then if you had another suite of our products, it updates all of those boards. But I think that the notion that I'm not tethered to the documentation station, which in many of our ORs means I'm facing the wall and not facing the team, is a critical part of why this has been successful for nursing implementation. And then just to close that, I'm going to show you my 3 favorite screens of our timeout. You won't be surprised by what these are. So the first one is all of the members on the team. If you entered these names into the electronic health record, they're all populated here. You can call each other by name. In that study that the Dutch anesthesiologist did, they found that the least known member of the team was the anesthesia resident, which is not surprising. So their name would be up here. Next. This is the basic patient identification information that came over from the EHR. And that last question about allergies, I just put there to say that I think there are some pause points that you need to think about that I mentioned before that you should not default and make people change. And then the last one, the last slide is the surgeon should have the last speaking part. You should start with the junior members of the team because they might not speak up if the surgeon said something. But the most important thing a surgeon can say at the end of the case is on the bottom of this slide. Does anybody have any concerns? If you see something that concerns you during the case, please speak up, and then you can start your procedure.
And Aileen,
Yep.
Sorry to interrupt, but just to make sure I emphasize something I fear I didn't mention, part of that bi-directional integration to your HR is as you click these things, the product's actually pushing the data back into the EHR. So not only are you freed up from the documentation workstation in the room, that data is captured back in the EHR. So you have the record you would have done had you typed, but now you can be standing up with the team.
And the other thing we've incorporated in here too is the fire risk assessment, which is another part that's is a standard now, at least in the United States. And if you answer the 4 questions of the fire risk assessment, it'll automatically calculate the score for you and put that score into your EHR as well. So lastly, just in conclusion, next Dave, lastly. So if you want to have positive outcomes for your surgical patients, you need to have both a successful implementation and full compliance of the safe surgery checklist. We talked about some of the implementation and compliance challenges, and we've talked about some different ways that you might intervene to rise up to those challenges, including modifying the way you deliver the timeout, integrating it into your practice, promoting clinician awareness, and also there's a component of managing your policies so everybody knows what the expectation is. And on that note, we will take questions.
Thank you, Aileen. Yes, we've got a few that have come in. The first question is, you mentioned improving communication throughout the surgical journey. How do you do that?
So the surgical journey, as we're defining it here, is through the part where the patient's into the operating room to the outside the operating room. I think all of those things we talked about in terms of calling people by name, addressing them, having conversations, having permission to speak up. There's been work done with our called crucial conversations. If you're concerned about something in the operating room, if there's not something that you're clear about, people have promoted using language that helps you escalate the cause and not make the other team members take it as offensive. You say, I'm concerned, I feel unsafe, this is a patient safety incident. You can escalate those things. I think part of the strategic plan is there needs to be some very senior people in leadership, whether that be the chief nurse, the chief of surgery, respected clinicians, who will come to your rescue if those communications aren't working. But maybe for another time, we also have other communication boards that, as the nurse in the operating room is doing all of these things, clinicians in pre-op and PACU are getting notified about the status of the families getting notified of the status of the patient. So that communication is happening through technology without people having to make phone calls, stop doing what they're doing, answer a phone, go get the information, call back because the other person was on the phone, et cetera, et cetera. So as Jeff mentioned, we've really tried to make the technology work to improve the communication and fit it into the workflow.
Just if I could add to Aileen, I think that's all correct, of course. But we're focused here on a subset of the surgical journey writ large. I mean, from that first clinic visit of a patient, weeks or months even before surgery to when they get home. And we also have modules that cover that part of the journey as well that we're not focused on in this time. But I feel, obligated as a sponsor to give a shout out to that. So we do have a planning set of modules that help clinic schedulers find available time in the OR that ultimately leads to the patient having a slot to have that surgery, et cetera.
Okay, well, another question that's come in is, you cited a lot of studies and surveys. Are those available for us to read in greater detail at all?
Yes, we will provide a reference list after you do your survey. We'll send it out to everybody who participated in this survey, a list of all the references I talked about, so that you can look at those studies yourself. And just as a geek who went to Ph.D. school and learned this little technique, some of the best articles you can find are in the reference list of those articles. So they quote other articles that might be very useful to you. So don't negate to look at the reference list, or when somebody quotes something in their article that you find really compelling, go find that article that they quoted. It's a really good way to build your argument for making this work.
Okay. We can't get our senior surgeons on board. What strategies have worked for you in the past?
So a couple of things. I think you need to find one. Hopefully there's one senior surgeon. He might not be the chief of surgery. She might not be the chairman of cardiology or neurology or wherever your problems is, but you've got to find a champion, and you've got to figure out how to get them on board a little bit. Nobody's going to say they're against patient safety, but you've got to find somebody who really believes this. And in most organizations, you can find that one person who will help you do some of this work. We've had that surgeon go into other surgeons' rooms while they were doing their timeout and coaching them. Atul Gawande actually has a really good article that was published in the New Yorker magazine a few years ago about how he asked somebody to come in and critique him actually doing the surgery, part of the surgery, how he was standing, what he was doing. So there needs to be mentorship. You need to bring those people on board. And if there is nobody in your organization, you need to bump that up somehow to the C-suite and figure out how you're going to get somebody to play in the sandbox. I can't believe that in every organization there's not one person who is respected, even if they're not a senior surgeon, who you can get to be your champion.
Great, thank you. Got time for one more question, and it's, we need to improve our timeout procedure before the Joint Commission comes. Do you have any ideas or low-tech ideas we could implement?
Yeah, so as we said, the Joint Commission has identified our active timeout as a best practice. Obviously, if you're in your Joint Commission window, you're not going to have time to get boards, get a process in place. I think the thing that you need to do initially is stress the active part of that active timeout. If you can improve your process by whatever your current methodology is, if it's a whiteboard, if it's a sign in the room, but making it active and making everybody have a speaking part and trying to get it to be so that the circulating nurse is just reading off a list of events and maybe skipping over a question because she knows that's one that the surgeon that they're working with today doesn't like. You'll go a long way to taking some of the principles we've tried to automate, but you can't automate a broken process anyway. So you need to fix your process to begin with before you can automate it and have it be successful. But I would really stress that notion of it's an active process. It's not a passive, read this list and put something in the record that says we did a timeout. There's tons of literature that says behind every never event, every untoward event is a bad timeout. So I think that's where you start.
Great, thank you. We're actually coming up to our hour, so we'll wrap up now. So thank you, Aileen and Jeff, for your time today and for a great and really informative presentation. Please visit today's sponsor website, livedata.com, to learn more about the service they provide to our industry. As promised, the answer to today's trivia question is Clara Barton, which in 1881, sorry. So congratulations to our winner, Robert Hantz. Enjoy your lunch bag. Just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit ortodaywebinars.live for more details of all our upcoming webinars and, of course, complimentary registration. Thank you once again for your time today, and we hope you enjoy the rest of your day.
Thanks, Linda, for your help.
Thank you.